the fact that we're spending trillions of dollars a day on an overseas war that most people are not supporting, that juxtaposition politically is huge for someone making the argument for Medicare for all, because the main argument against it is always we can't afford it. So, again, does that mean it's going to happen? No. But I think change does allow us to have more fundamental conversations. Hello, everybody, and welcome to the Integrated Care Podcast. My name is Neftali Serrano, if you can roll your R's. We are happy to have another episode today of the Integrated Care Podcast, here sponsored by the Collaborative Family Healthcare Association. I am joined by my co-hosts here, Jen, Bridget, and Ashley, and we're just going to jump into today's topic. It's something that all of you out there are experiencing on a day-to-day basis. I can guarantee you, you all are experiencing this to the nth degree, and that is change. And our hope today in today's podcast is to actually give you a glimpse into how the change in the world across a variety of different areas is affecting healthcare workers. So if you're a healthcare worker out there, we hope that we can channel you and help give voice to the things that you're feeling as you go into clinic each day. And if you're not a healthcare worker, someone that's just listening to this podcast, we hope to give you a glimpse as to what it's like to be a healthcare worker in today's day and age. We're going to have a broad ranging conversation on this. We'll cover things as broad as AI and how that is filtering down to us. A lot of the federal stuff here in the United States that has significant impacts on healthcare and on our patients and communities. And then, of course, there's just a specter of some of the global instability, including war and a lot of that bad stuff that we see happening. Now, before we get to that, I just want to quickly allow my co-hosts to say hello and tell us where they're coming from today. So, Bridget, can you start us off and remind our folks where you're coming from today?
Yeah, coming from the state of Washington, working in a federally qualified health center.
Awesome. And Jen,
Yep,
you are close to the middle of the country.
I am. Yes, Northern Illinois, Morris Hospital, Family Medicine, Addiction Medicine, and co-medical director, CFHA. So good to be here.
Awesome. And then, Ashley, you're not too far from Jen.
Not at all. Ashley Garrison. I'm the pediatric dietitian at Burlington and Mebane Pediatrics in North Carolina.
Yeah. And actually, Ashley is closest to me. I am in Chapel Hill, North Carolina. I'm the CEO here at the Collaborative Family Healthcare Association. All right, let's jump in with just a broad question, okay? This change that's happening in the world, when you think about how it's affecting you and your teams, what's the first thing that comes to your mind?
I'm an optimist, I would say, and so not trying to be invalidating to the environment, but you asked the question. This is what came to
Yeah,
my mind.
no, yeah.
Is I think there's an opportunity to redefine what healthcare is. I think there is an opportunity to look at all the social drivers of health and the behaviors and to restructure the safety net of the United States in terms of that your health is very contingent upon your psychosocial aspects. And so if you are somebody who's being directly affected by a policy, an immigration policy, or maybe you're a spouse of somebody who's in the military, those things are going to directly impact your health. And so being able to understand that we have to find out about a person's context, and that is a key driver, and that your healthcare team has to start from the psychosocial lens. I just think we have a really good opportunity to redefine what health is, and for mental and behavioral health specialists to get out of their silos and stop trying to be diagnostically based and stop trying to figure out what's wrong with people and join primary care and meet people where they are and help this system be better. So that's what's on my mind, is how the heck we can make that happen. I want 100% penetration rate of 100% of the patients are coming in to see a BHC. That's the way my brain's working right now.
Bridget, you stole my thunder there.
Yeah.
All right, I'm not going to talk more about that yet because I want to
Okay.
hear from everybody else. But yeah, I think you're onto something here. I think you're onto something. Jen, how does this change filter down to Morris Hospital in Jen
It's-
Thomas's life?
Oh, that's a loaded question, and we're on the record, so I got to be careful. I think I'm overall an optimistic person, but I am sad to say I'm pessimistic coming at this from the healthcare provider PCP standpoint. I was just having a conversation this morning with my nurse practitioner colleague, and we were like, our penetration rate sucks. Like our flavor of integration is okay, but we're not meeting the need. And it's not just the model, it's all sorts of workforce issues and turnover for care managers and shared vision or lack thereof from like leadership, that there's barriers. But I don't have a Bridget in my pocket. I was literally saying to Kathy this morning, like, wouldn't it be great if we like changed up how we did things and we had a BHC just like hanging out with us and they just dove right in? We don't have that. And I'm a middle manager where I am. So like bringing ideas for change because change is hard. If we did integrated care and we're done, we're good, it's happening. We're 7 years in, so we have a lot of like drift and sustainment challenges that it's better than nothing. I will say I like how I practice now better than I did 8 years ago where I had no BHCM, COCM, any kind of support. So it's better, but we have a long way to go, I guess is my 2 cents on that. So
Yeah, and I know because we've talked, Jen, that the external environmental pressures on your hospital system filter down to you because their stress becomes your stress. I'm assuming based on our conversations that that stress has not decreased over the last couple of years. It's probably increased, right?
yeah, because it's always do more. Like providers, can't you just see a few more patients? Can't you just squeeze a few more acutes in there and double, triple book? We could, but do we want to have our providers show up tomorrow, or are they going to just quit and go work in retail? Because a lot of them do. Not in my, some of them in my system actually, but like categorically, like a lot of people left the healthcare biz, PCPs, blame COVID a bit because that, yeah, certainly, but we have a workforce, I don't want to say crisis, but as a group, we're a grumpy bunch as far as how our wellness is or is not showing up every day in practice. I sound so pessimistic. I think I like to be optimistic, but I don't know. It's hard to be sometimes with those pressures that don't align with. I think that's the thing I learned from you guys with all the contextual psychology stuff that like nobody ever taught me is, oh, it's incongruent with values. You like to show up for your patients and feel like you're doing something, but when those other pressures are like, yeah, but you need to do more and see more, and when you're off, you're not really off, and you come back and your inbox has 40 and you're like, well, I had coverage, but we just don't communicate. It's yeah, then it doesn't feel like you are living your values so much.
Yeah, and I think that's a little bit of the silent killer in healthcare that I was hoping folks out there get a feel for because you have these big things that are talked about in the news, like Medicaid cuts, for example, right? Or you have the vaccine conversations. I know we talked about that last time and vaccine hesitancy and all of that. And obviously went through all the controversy around COVID and the pandemic 6 years ago. But that kind of stuff has real world impacts on the day-to-day lives of people who work in healthcare. And what we've seen certainly over the last few years is a lot of people decide this ain't for me. I don't want to deal with this. There are some real impacts on just your nurse out there, your BHC out there who decides, you know what, my system doesn't value me. I'm just going to go into private practice and do better help. Like those are the decisions, or your psychiatrist that decides I'm just going to go self-pay and have my own little hang up my shingle, right? There's real world consequences to that. All right, Ashley, what are you feeling in your corner of the world in Mebane?
I have to say, I'm very lucky that I'm at a place who absolutely adores change as much as I do. And I'm super proud of some of the things that I never even thought of having come from a big medical facility where you are in your own little silo and the outside world, dare I say, doesn't affect you as much as it does when you are in primary care. And so, for example, the first thing that popped into my mind when ICE was a really big conversation and a very big threat, and our leadership got right on it. They put signs and policies and procedures in place to really protect our patients, things that if patients weren't making it and they weren't able to call fall or whatever, they didn't necessarily just dinka them because that was the policy, right? We dug deep and tried to support them so that they knew we were a safe place that still wanted to take care of them. And we would do that on their time and support them through that time. And that's one of the biggest things, I think, in terms of this federal wild change that we're like, wow, is this really happening right now? But it was affecting a lot of our patients and our neighbors. And all three practices did a fantastic job of really making sure that our patients knew, when you walk through these doors, we got you. You're protected. We are not going to let anything happen to you. We're not going to talk to anybody unnecessarily. They gave us scripts of what to say in case somebody did walk through the door. And I do think the world is ever changing, better or worse, no matter which way we look at it. Me specifically, when I'm thinking about the Medicaid cuts, that was a big one. We started a weight management program here for teenagers 12 years and older who were dealing with obesity and secondary chronic diseases, and Medicaid at that before the cuts was covering GLP-1s, great medications. We were super excited. And then I think we were a month into it and they said, which has really affected our patients. But we're like, okay, you want to do this? We're going to plot twist and try to find some workarounds and still offer that program and help. But yeah, I feel like every time we turn around and we think, okay, we're moving in the right direction, we get right hooked from the other side and we're like, okay, we got to come up with a new idea.
Yeah, and I think you're speaking to the sort of adaptability of our teams, right? So yes, there's a lot of changes, a lot of things that are coming down the pike on us as teams and as healthcare professionals. But I think I would agree. I think my sense is we are a resilient bunch in healthcare. This is not our first rodeo with big changes happening and dealing with them. And it is nice to see that the teams react. It would be nicer if we were, I think, better supported in general, and people understood the downstream impacts of all this change on our teams. Now, you guys have talked about your organizations a lot in this first go round of questions. What do you think makes for an organization that adapts to this change effectively? Looking at the best parts potentially of how your organization has moved to support teams, like what's important for teams to be supported by their organizations?
I think leadership is going to be crucial. To Ashley's point, leadership from like a organizational systemic point came in. I think that it's important for leadership to digest the changes that are happening, and then you craft a plan for how we're going to adjust. Like you said, you adjust and then the rate hook comes. Okay, now you re-up and adjust. That's, I think, being able to cast a vision to those around you or who report to you or who you can influence, to say, all these things are happening and that sucks, and here's what we can do still. And it's, if you think about good old therapy, and counseling skills, it's controlling what you can and impacting where you can. And maybe that makes it seem too simple, but I do think that when things get crazy, going simple is a really good place to go. And so right now, we're in an FQHC in Washington State, so our context is more fertile than Jen's, for example. So there is an opportunity, like we know what we need to go do. And so with my team, when everything's swarming and things are crazy, I want them to know what they need to just go and do. So it simplifies things. And I think that a good leader needs to be able to have that skill set no matter where you are. If you're the CEO, then you're going to be taking on bigger and bigger systemic issues. And then if you're the COO and the clinic manager and whatever else you have, is looking at your department and say, in this situation, what are we going to do? And what can we do to make a positive impact? And I know I'm making it sound like, oh, you just do this and it's so easy, but it's not. So I don't know. Hopefully it didn't come off that way.
But Bridget, I 100% agree. And I had two adjectives that popped into my mind, but you just totally explained it way better than what I was going to say. I feel like whether you're a leadership, whether you're a clinician, I think awareness and communication. And I think those, if I had to put two adjectives together of, hey, we can't control a lot of things, but here, let's be aware of what's going on and let's communicate with each other on what, to your point, what can we control? What can we do? What can we do what can I do in Meb in North Carolina? What can you do in your clinic in Washington? What can Jen do? What can Neftali, like, what can we do? And that's across the board, to your point, from CEO down to a dietitian in a small town. Like, being aware and communicating with whomever you can communicate with to try to give the best care to our patients no matter where we are. So I think you said it eloquently and beautifully. 10.
Yeah, I agree. And I don't mean to come off so glass half empty this fine morning because it's a beautiful day in Illinois and the sun is shining. But there's a lot we're doing right. I think I love the like coming back to the who you're seeing, the families you're helping, and the person in front of you. That's the work, and that we do well, despite all the operational challenges and sustainment metrics that you're not meeting yet. Yeah, that you get lost in that noise of that feedback of this is not enough culture versus what about the real human connection? When you think about that, and that's I think where I think my system has succeeded is we've had a good provider championship. We're like, yeah, we all acknowledge like healthcare is broken, but it's nice when you do have a win of, hey, we had that BHC talk to that family of that child that had school anxiety and now he's back at school. So those wins 100% keep us going when it's like, the tides are, you can't push against the tide, you'll get swept out to sea. But there's little lifeboats, there's little glimmers of hope and all that.
Yeah, and I think, zooming out to the super large level and coming back to your comment, Bridget, times of change are opportunities as well. And one of the things that I keep reminding myself of is we never wanted healthcare to be the way it was anyway. Because like we've been battling the same shit for my whole career, and I know past before my career, other people were still battling all the fragmentation, all the inefficiencies, all the issues of burnout. Those are not new issues, right? And so it's not like we want things to go back to the way they were. And if there's any solace I do take from all of the change, it's that in a way we're getting a master class right now in how important all these different factors are to delivering good healthcare. We're getting a master class on how important it is to involve immigrants in healthcare, not silo them. We're getting a master class in why vaccines are important. We're getting a master class on the inefficiencies and the ridiculous price issues in healthcare, whether it's pharmaceuticals or the way that we value like procedures over preventative and early intervention care that we provide in primary care. We're getting a master class in all this stuff, right? We're getting how important Medicaid is. Like people are actually talking about these things, right? 10 years ago, it was us talking about it because we're in it. But now it's actually a larger conversation. And this is not like CFHA's official position. CFHA doesn't have an official position on this. But I actually think, to your point, Bridget, I think we are closer than we ever have been in my career to actually talking about things like Medicare for all as a group. I think there's much more consensus within medicine because for those of you out there who don't know, provider groups have in the past been anti Medicare for all. Like physician groups and historically have been against those sorts of pieces. And I think that tide has changed internally. And I think in the larger conversation in the United States, I think there's a larger recognition. I think one of the ironies of this war in Iran has been that the juxtaposition, just like putting them side by side, even though they're not specifically connected, the juxtaposition of the Medicaid cuts that are going to hit us here in 2027 that are related to the tax cuts that are mostly going to wealthy individuals and corporations, and the fact that we're spending trillions of dollars a day on an overseas war that most people are not supporting, that juxtaposition politically is huge for someone making the argument for Medicare for all, because the main argument against it is always we can't afford it. So again, does that mean it's going to happen? No, but I think change does allow us to have more fundamental conversations, to your point, Bridget, about simplifying things. What are we here to do in healthcare? What are we trying to accomplish? What do we need to do that? Right? So who knows what's going to happen? But I do feel like we at least are having conversations, hard conversations that we maybe weren't having as directly before. So that's my version of glass half empty, half full, sorry, half full.
And I want to piggyback on that for a second, Naftali, because yes, Bridget, we're simplifying and maybe that doesn't feel right. But also I think what we're doing as an association is just that. Let's bring behavioral health and mental health specialists to where people come to get their physical health better. And then y'all allowing me to be in this group of cool. So we're taking care of the brain and the mental and psychological piece and the emotional piece, and we're taking care of them physically. And then allowing me to come and be like, let's fuel your body so that we can sustain both your mental health and your physical health for as long as humanly possible. When we break it down, that seems so simple, right? Like it's such a simple concept. Like we have a doctor that's going to take care of you physically. We have a BHC or a psychiatrist or psychologist or therapist, whomever, who's going to help take care of you mentally. And then you have a dietitian who's going to help take care of fueling that so that both of those longevity. It sounds so simple, but it is really such an not widely accepted and utilized and universal idea that we're bringing to the table.
You think about one of the home organization I work for is Community Health of Central Washington, and we were beating our head against the wall of, hey, what are we trying to, how could we message that a person's social health and their behaviors drive overall healthcare, and also how do we get everybody on board with this idea that we are population-based health as well. There's population medicine. Our CMO does a great job of looking at population medicine. And I was like, you know what's interesting? It's found right in our name. What are we doing here? Community, trying to support the community. Health, to Ashley's point, I'm not only caring about mental health. That just happens to be my angle, or behavioral health. It's my angle, but the overall goal is health. The same way as a dietitian, yeah, the angle you're going to take and the piece you're going to help them with is how they can feel their body, but the ultimate goal is their health. And a physician, same thing. So we all have the same goal. So if me, you, and Jen worked on the same team, we might have a slightly different angle, but we'd have the same goal. So health, and then care. We care. Like community, health, care. It's built in. It's like ridiculously simple. Then the turf wars and the silos, and I'm here to talk about mental health. I'm like, I don't, and this is provocative on purpose. And I've said things like this before. I've said things like, I don't care about PCBH, which I meant what I said at the time in the context, but I don't give a shit about mental health. I only care about mental health in as much as I care about health and the community, because we're community health.
Yeah.
Yeah, I feel like that should just be a mic drop right there. I think I think that's one of the things I'm getting from our conversation today, which is really interesting. It's not what I thought I'd be leaving with, but I think one of the adaptive responses to change is clarity, right? And it's clarity about fundamentals and fundamental values. So Ashley, what you talked about, to me, like hinges on one of our core values here at CFHA, which is teams, right? It's the idea, it's just that really basic fundamental idea that the most important thing is the team. And when we come into a team, Jen and I were talking about this here as we attended a conference this week, as one of the prerequisites to joining a really highly effective team is just the willingness to check your own baggage at the door and say, hey, my work here is to support this team. And of course, the way we define team, the patient and their families on that team, right? So are our colleagues, our medical assistants, our front desk staff, our billing people, just as much as our providers, our dietitians, our care managers, whoever else is on the clinical part of that team. And so the ability to revision yourself because you have clarity of vision around what you're actually trying to accomplish, which Bridget, you said so eloquently. Yeah, we're really here trying to foster health. And through that, trying to do that at scale so that we have healthy communities that promote more health, right? Because communities are actually the thing that promotes the most health. right?
Yeah.
It's not actually us, right?
Yeah.
I think that's one of the things that can come of it. And maybe one of our take homes
Mhm.
today is clarity can come from times of significant change.
Yeah, I agree. There's never been a more important time for integrated care and teams and trust in your local community, right? Your local PCP and the Bridget that you've seen over and over again. So in those turbulent times of, it's reminiscent to COVID part one, where it was like there was all this misinformation around vaccines, and it's like your patients come to you with like, I don't know what to do. Who do I trust? In those times of like chaos, it's never been more important to have a trusted local expert that you can talk through the
Yeah.
ambivalence and the like, what does the evidence say? I'm hearing this from national leadership and HHS, whatever. But to really sit down with the person in front of you, like, this is what I know to be true. This is my years of training and evidence based expertise. Yes, go do your own research, but also trust your experts. Like my grandpa Mick was always like, consider the source. That was his favorite saying when someone would be talking shit, and he'd be like, okay, but if consider the source. If you're looking to an expert that you trust and know, that's different than the tides of who's in charge these 4 years or not. I don't know, getting political, but I think integrated care, these are people you can develop relationship with. And that makes me sleep better at night, that I can take my kids to a provider that like, hey, I know you, tell me what you think about these changing times and recommendations. Where should we go with this? Help me make the right decision.
Awesome. We're coming up to the end of our podcast here. We didn't even talk about one of my favorite topics to talk about today, these days. Not because sometimes people think of me as a little bit on the techie nerdy side, and I am a little bit on the techie nerdy side. I'm a guy with a 3D printer, for heaven's sakes. That's just pretty much labels me. But artificial intelligence, and maybe we can talk about this at a future podcast, but 30 seconds. Are your patients coming in having asked ChatGPT like ahead of time, what do I do in this situation, or what do I do with this medicine, or whatever?
Oh yeah.
Not yet. I think they will more and more. My N of one is I used AI for, I will admit this, one patient encounter, and didn't help me. So I was like, screw it. Because I think, Bridget, you like to say in primary care, it's got to be like road tested, it works or it is out. And I'm not saying it's not good technology. I need to get better. I was not properly trained, but that's how quick we have to like change and adapt. So I think I'll go back and get properly trained, and it could help me at some point. But yeah, I guess I'm more on the like hesitant side. Although I do use ChatGPT a lot for wordsmithing, like editing, and I think that's a really helpful thing to get your point across in a way that's not so verbose like I tend to be, of like, this is what you want to say in 2 sentences instead of 2 paragraphs, Jen. Okay, cool. That I can get on board with.
Yeah, I'm trying
Most,
to.
sorry.
Oh no, you go ahead. No, Ashley, you go ahead.
I was just gonna say most of my teenage patients are the one that I'll be like come to me talking about creatine or this or protein. Chat GPT said, and I'm like, that's wonderful. Me and my degree and my medical experience say.
That's awesome.
Yeah, I try to work as much as I can, like with it and stuff, and help people to, if they do use, a lot of them will tell me that they use chat bots and stuff and chat GPT or whatever. And sometimes I'll just ask, what did it say? And sometimes I'll encourage them, like, hey, I think it's great that you're stopping and thinking this through and trying to flesh out the best way to approach your best friend or the best way to think about this. And so I try to take the good parts of it and
Yes,
elevate
take the good.
those.
Mm-hmm.
So,
Absolutely. That's a
and
good outlook.
I haven't, I probably need to get more technical skills of it, but I use open evidence a lot and find that
Mm-hmm.
to be helpful. And I actually have used ChatGPT a few times myself as a clinician and say, hey, I'm thinking
Mm-hmm.
these two things. Could you simplify this for me or put this in layman's
Yeah.
terms for me?
Yeah.
So I think it's like anything, right? Like it does scare the crap out of me. And
Yeah.
I feel like I've said this on another one of our podcasts, and I'm really happy that I'm like on the other half of life and more towards death than life because I'm like, I don't know if I want to, like,
Live
I'm
in this
so,
world. I don't want to live in this world of
yeah, like,
robots controlling us all and
I'm
taking over
so
humanity.
happy that I'm 40 because I had 40 years without dealing with this shit. But
Hopefully you have another 40 or 50 in you. So we'll just
yeah,
have to
and maybe
make
I
it
won't
work.
care as much about stuff, or I'll be knowing, like, oh, I only
Yeah.
got 30 more years. Whereas if
Yeah.
you were like 10, you're like, oh my God, I got 75 more years or
Mhm.
longer, depending on if healthcare does get better.
Yeah, yeah. And I do have to say, shout out to ChatGPT's chatbot. I literally didn't know what a chatbot was till Tuesday at the meeting Naftali referenced, and I was like, CFHA has done a great work on measurement-based care. They have this top 40 outcome measures in primary care. So I was like, let me just click on this thing. Was interact with this data with a chatbot. I was like, what's a chatbot? But I literally typed in, okay, if I was going to build a workflow around these screening tools in primary care, what would that look like? And damn if it didn't come out with a really pretty, here's how you do this. MA does these measures, and this is how you track it, and here's how you meet these NCQA measures around looking at whether they had follow-up or whether they had remission or response. And I was like, huh. So I guess I'm an early not naysayer. I'm like, okay, I think there's something to this. So cautiously optimistic. That's my 2 cents.
Oh my God, I forgot. We have Mike Bruner who's active in CFHA. He made the Beachy Bauman GPT.
There you
And
go.
so
Yeah.
what it does is that he uploads every one of our PCBH corners and videos and stuff to it. And
Yeah.
then if you ask it, so I ask it stuff all the time. I'm like,
Quote me to me.
yeah, what the hell did I say about whatever? No. But I'll be like, find me this episode, or
Yeah,
can you make it back to your point, Jen,
that's
about
good.
like,
Yeah,
can you help me to be more eloquent and to the point? Because
yeah,
I'll have some,
that's
you
the
know,
good. Lean into the
meandering.
good. Yes, there we
One
go.
of one other good I want to add, y'all, that all of my providers use and are obsessed with, at least for documentation and sort of pediatric primary care, is this AI Freed is what it's called. And so they love it, and it has cut down on their documentation time tremendously.
Okay,
I
that's
will
what I need.
share. I am still a pen and paper gal myself. One time I scritched with a little pencil, and my teenager patient was like, "What is that?" So I'm not quite there yet. I will get there eventually, but all of my providers absolutely love it, swear by it. When it went down one time, everybody was like, I don't remember how I did this before this. So that's another one of the good things that I will share, that I think it has really streamlined and made things that normally took a lot longer happen a lot quicker. So we can spend more time with the patient doing more quality care rather than sitting doing sort of the typing and the documenting and the part that's not so fun part of our job.
Thank you all today for taking a conversation that can be fraught with heaviness and anxiety and reframing it to a conversation of opportunity and clarity and a chance to dig into values and what's really most important to us. I've really been inspired by our conversation today. Thank you all. And thank you to our listeners for doing the work you do each and every day. Thank you for listening here on the Integrated Care Podcast. Till next time.